Hello and welcome to the Cleft Mama podcast. This is a supportive space for families navigating life with a baby diagnosed with a cleft lip and/or palate. Here we share real experiences, practical guidance, and conversations with parents and professionals to help you feel informed, supported, and less alone. I'm your host, Anja Paunel, and I'm excited to get started. Hello! Today I want to talk about different types of clefts and give a brief overview of how they are treated. So first of all, I want to start with some terminology. And it's called a cleft lip or a cleft palate. And cleft actually means split or separation. So this is actually a bit of a misleading or in fact a wrong term, because in early pregnancies, different parts of the baby's face develop separately and then they join together. So if some parts don't join together all the way, then the baby is born with a cleft. So it's not that something has been separated or split, it's rather that it's never grown together properly. Also more on the terminology as well, if we were to categorize or classify a cleft lip or a cleft palate as well, this would be a birth defect. I know this is not a nice term and it can be a bit triggering, but it is a congenital condition, congenital meaning it's present from birth. It's not a disease and it's not an illness. Let's come to the different types of clefts now. And it's important to remember that no two clefts are the same. There will always be some differences, but they can roughly be categorized. Let's start with a cleft lip. A cleft lip describes a gap in the lip, and that can really range from just a slight notch in the colored part of the lip, or it can be the colored part of the lip and also the skin part of the lip, which would be an incomplete cleft lip. And if it's only a notch, they can also be differentiated really into a mini microform cleft lip, a microform cleft lip, or a minor form cleft lip. So all of these would be incomplete cleft lips. The gap could also be from the lip all the way up to the nostril or the part of the nose. And this would be then a complete cleft lip. And in general, with the cleft lips, they tend to not be in the center of the lip, but downwards of a nostril, so to one or the other side of the center of the lip. So the philtrum, which is the part between your nose down to the lip, or the curves in the center of the lip, which is called the cupid's bow. So this part is called the philtrum, and you have two columns on the side of the center, which are the waist parts of the philtrum. And then you have a dimple in the middle where no muscles are behind. And the cleft lip tends to be towards the side of the philtrum. So the philtrum is still intact, and then you can either have it on one side, which is a unilateral cleft lip. And in this case, the philtrum tends to be not central, but pulled towards the side without the cleft. Or a cleft lip can also affect both sides, and that's called a bilateral cleft lip. In the case of a bilateral cleft lip, the philtrum is central and in the middle, but it is raised up. In 20 to 30% of unilateral cleft lip cases, there is a bit of tissue connecting the sides of the cleft lip, so either directly under the nostril or in the gums. If there's still some tissue that's connecting and kind of bridging the two sides of the gap, this is called a Simonard's band. The upper gum, which is called the alveolus, can also be affected, and there can either be just a notch in the gum or it is completely missing. With a complete cleft lip, the nose can also be affected, and that is shown as the nostril being stretched across the gap. So a cleft lip is visible when you're looking at the baby, and that can already be seen in the womb. So that can be detected in a scan. Most often it's seen on the 20-week scan. So if that is detected on a scan, then it means that at least the parents can be prepared for the situation and they can do their research before the baby is actually born. Coming to the cleft palate, this is inside the mouth. which means the roof of the mouth has not joined up properly and there remains a gap. So the roof of the mouth is called the palate. The front part, which is towards your teeth and the lip, this is called the hard palate. And the part towards your throat is called the soft palate. People say that if you feel inside your mouth with your tongue, you're able to feel the difference between the hard and the soft palate. I can't quite feel that. If I try to get to the soft palate, I just trigger the gag reflex. So I can't really feel that, but apparently I'm meant to feel the difference between the hard and the soft palate. A cleft palate can affect both the hard and the soft palate, or only the soft palate. Those are inside the mouth, so they're harder to detect on a scan because you need to look inside the mouth. So sometimes they're detected on a scan. For example, if the baby is yawning, sometimes sonographers say they can see inside the mouth and can see a cleft palate. Now we have a lot of combinations of that as well. So if the cleft lip is affected, then the palate can also be affected. And that's the case in about 60% of where you have a cleft lip diagnosis. The palate is also affected. And that can then either be the hard palate or the hard and the soft palate. If the lip is not affected, then a child may have a cleft palate of the hard or the soft palate, or only the soft one. And that might be missed at first. So even when the baby is born, they may not immediately see that. And it's only when the child then shows that they are feeding difficulties and they can't nurse by themselves, that then maybe after a day, hopefully only after a few hours, it is detected that the child actually has a cleft palate. Now, if there is a cleft palate, then the uvula, which is the tissue that's, if you were looking in your mouth, it's the tissue that's dangling in the back central part of your mouth. This may also be split. In rare cases, it can also be that a child had the cleft lip and the cleft palate, but the nose and the gum are actually intact. There can also be the situation that there is a cleft in the muscles of the palate, but not in the lining of the mouth. So that makes it very hard to see, because if you're looking inside the mouth, there is no visible hole, there's no visible gap. It's only underlying in the muscles part of the palate. So this is called a submucous cleft palate, and this may be actually missed for years. So this really relies on parents being insistent that they think there are difficulties with the speech, for example, or feeding of the child, that this hopefully leads to the submucous cleft palate being detected. Another situation we might want to talk about is the Pierre-Robin sequence in English, or sometimes they might also use the French wording Pierre-Robin sequence, which is a sequence of events. So here, very early in pregnancy, which is often around the 7th to the 11th week or so, the baby's lower jaw fails to grow at the normal rate. So it's just growing much slower. And this results in the baby having a very small lower jaw. And because that jaw is too small, there's just not enough room in the mouth for the tongue, which means the tongue is forced into a high backward position where it rests against the roof of the mouth. And because of that position of the tongue, this in turn blocks the sides of the palate physically from moving to the center and fusing together. So as I mentioned before, a cleft palate is where the two sides of the mouth, the two parts of the palate, couldn't grow together. And in this situation here, it's the tongue that is physically located in this gap, and it prevents the sides to grow together. So this then results in a U-shaped cleft palate, or sometimes a very high arched palate. So children with a Pierre-Robin sequence also have a cleft palate. Now, if we're speaking about all the different types of cleft lips and cleft palates, I might as well introduce the abbreviations that you may have seen written somewhere. So PRS is quite often used for the Pierre-Robin sequence, which I just described. And you may also see UCLP, which means a unilateral cleft lip and palate, or a BCLP, a bilateral cleft lip and palate. Around 1 in 700 babies are born with a cleft, which means it's about 1,200 babies every year in the United Kingdom. On average, 45% of babies born with a cleft will have a cleft palate alone, an isolated cleft palate. About 25% of babies with a cleft have a cleft lip alone, an isolated cleft lip, and around 30% of babies with a cleft has a cleft lip and palate. And the smallest proportion, so that's around 9% of babies born with a cleft, have a bilateral cleft lip and palate. If a cleft lip is diagnosed, as I mentioned before, in around 60% of cases, they also have a cleft palate. Today, I want to also talk a little bit about the treatments for a cleft lip and or cleft palate, but I will go in much more detail in a future episode. So in the UK, it is a team of specialists that are responsible for the treatment. They're called the Cleft team, and they are specialists who treat different conditions caused by the cleft. So this cleft team includes the surgeon who will repair the cleft and later also the bone and jaw if there are any repairs done, a pediatrician, an orthodontist, a pediatric dentist, then a specialist nurse or a specialist health visitor, a psychologist, a speech and language therapist, an audiologist, an otologist, and a clinical geneticist. So those are all people that can be involved in the child's care if and when it's needed. The first point of contact is generally the cleft nurse, who gets in touch generally already during pregnancy if the diagnosis was made at an early scan, at a 20-week scan or so. And she is normally following along the baby's development in the first year. I want to emphasize, though, that most babies born with a cleft lip and or palate are perfectly healthy. However, the cleft needs to be treated. So the main treatments are the surgery, which are the primary operations to repair the cleft lip and the cleft palate. An operation to correct the cleft lip is usually done when the baby is 3 to 6 months old, and an operation to repair a cleft palate is usually done between 6 and 12 months. And if there is a gap in the baby's gums, this will also be repaired as his or her second teeth are coming through. This is how it is in the UK. There are definitely differences to other countries, but what I'm talking about here is for the UK. Later on, a child might have operations to make some adjustments to the previous surgeries or to help the child with their speech. And the cleft team is also involved in some other parts, so there will be feeding support. This will really be from day one. So the cleft nurse generally comes out within the first 24 hours of a child being born to check on the feeding and to help with bottle feeding, or if it's just a cleft lip, breastfeeding, for example. They will also monitor the hearing, and the hearing aid may be fitted or small tubes called grommets may be placed in the ears to drain the fluid. Then the child may also receive speech and language therapy. There might also be orthodontic treatment or braces if their adult teeth aren't coming through properly. But I will discuss all of these in much more detail in future episodes. And I agree, this sounds like a lot, and it's probably quite daunting and scary as well. I just want to reassure you, first of all, not all of it will happen at the same time. So this is spread over the child's childhood or even into the first adult year. So not all of it happens at the same time. But most importantly, the majority of children treated for cleft lip and or palate grow up to have completely normal lives. Most affected children will not have any other serious medical problems, and the treatment can usually improve the appearance and the problems with feeding and speech. The surgery itself to repair a cleft lip may leave a small pink scar above the lips, but this will fade over time and become less noticeable as the child grows older. Most importantly, you are not alone. There are actually quite many kids out there. It's 1 in 700, so that sounds quite rare. But if you are reaching out, you will definitely find other people in your area. And as the children get older, they can also have some friends who actually have a cleft lip or palate as well, to just feel like they're not the only ones and feel less alone. And likewise for the parents, try to see if you can talk to someone else who can understand the best how you're feeling, because they're going through it themselves. You've got this. I see you next time. Thanks.
Thank you for listening to the Cleft Mama podcast. I hope you get a ton of value out of our time together. You're not alone in this journey. And remember, you're doing an amazing job. If this episode helped you, please follow and share it with another parent who might benefit from it. See you next time.